today. I'm Gareth Thomas. I'm the Digital Innovation Director at Health Innovation Manchester, which is a shared role with the Greater Manchester Integrated Care Partnership, as you can see. By background, I'm an intensive care consultant in Salford, where I've been for 18 years and continue to practice. So many of these issues that we'll talk about today, I see on a daily basis on the front line. So my talk today, what I'm going to do is run through something around our digital innovation strategy, which is based upon the three themes of digitize, integrate, and innovate. And then I'm going to give you some real-world data about what it is we're actually doing with digital and data to address inequalities right now. And I know Oliver will pick up on some of these things a bit later on in the morning. But before we get into the vision setting, there's just a few slides I want to give you just to sort of bring to life some of the challenges that we face in Greater Manchester. So Greater Manchester has the ambition to be a world-leading digital city. We know that we've got 10,000 vibrant businesses, we've got £5 billion worth of investment in the tech sector, and last year there were over 60,000 new jobs advertised in tech. So this is really where we're aspiring to go, and if you look at the GMCA digital blueprint, this really outlines very clearly our ambition as GM. But there's a disparity here between what we see in our overall ambition and what I and others witness in healthcare. In the worst case scenario, many hospitals or some hospitals are still using paper-based systems. So if we're going to really transform how we care for patients, how we address inequalities, and how we enable individuals to take over their own care, then digital is at the heart of all of this. So with this background, that the Greater Manchester Digital Transformation Strategy has been launched earlier this month. Before I talk to you about that, just a bit of context. I won't go through all of these stats, but we know, all of us in this room, that there are real inequalities in terms of healthcare access and provision across Greater Manchester. This was something that was really brought to life for me when I was on the intensive care unit in the times of the pandemic. That really demonstrated how some people in our society just have a much worse health experience. We know that in some areas, the disparity between across life expectancy is 17 years. We know that 26% of children live in poverty. And there's strong correlation between employment and health conditions. So these are the types of things we need to consider when we're planning our digital approach to transform health and care. Digital inclusion is extremely important and must be at the forefront of our thinking. We mustn't create worst digital exclusion via use of digital technology. We know that up to 500,000 people in Greater Manchester are classified as non-users of digital tech. Over 40% of benefit claimants have very low digital inclusion and engagement. So when we're planning our digital strategy to transform health and care, this has to be at the forefront of our mind. How do we ensure that we're improving the health experience and care delivery for patients and not inadvertently making this worse for some people in our society? So with this as the background, I'll tell you a little bit about what we've done with our digital maturity assessment across health and care. So this was a major piece of work in the last 2 years or so, and it's just been launched in September. We did 35 maturity assessments across our parent organisations, including the integrated care system. We listened to over 500 people, and we've got 1,700 digital and data maturity points to give us a really clear view of what is the digital capability in any particular care setting at any particular time. This really was leading edge work and has now been adopted by NHS England and has been rolled out across the country. And I think what we've got in Greater Manchester is a real opportunity to link our maturity assessment to our strategy, to our delivery. And I'll talk a little bit more about that now, and then I'll talk about how this is helping us address inequalities. So the strategy has enabled us to come up with 5 key ambitions which run through everything that we do. Safe, coordinated care, a workforce that is productive and efficient, citizens who are empowered to manage their health needs, and right at the far end there, an understanding of population insights and an ability to put research and innovation into practice. And this is really where we can start to address the inequalities, and that's what I'll describe to you a little bit later on in the session. So these are our 5 ambitions which run through everything that we're doing. These are supported by 3 layers of activity across Greater Manchester. Digitise, right at the bottom there. This is infrastructure, tech, capability, essentially levelling up capability across our health and care settings. integration, connecting patients and professionals with information across all care settings. And then on top of this, the ability to innovate and deliver new models of care, new population level insights across 2.8 million people. So it's an ambitious strategy with 3 layers of dedicated activity across the city. Just want to say a little bit about how did we actually sense check this. Well, for each one of those 5 ambitions, these are based upon what people have told us. So I appreciate the text is quite small, but if you look at the top left, people have said they want to be confident that people have got the medical history, that people are working together to make their best decisions, that the health and care professionals can be trusted to handle data in a secure and sensitive way. Professionals have talked about how digital should enable us to address clinical safety, reliability, continuity of care. So all of our ambitions are based very strongly in the narrative that we heard from those 500 citizens and practitioners across Greater Manchester. So I'll talk briefly now about the 3 layers of activity, and then I'll talk about what it is we're actually doing with those population level insights to innovate. So this first piece is around digitize. How do we level up across our providers to ensure that if I'm going into a care setting as a patient, I know what the digital capability will be and it's consistent across the city. We've got 1,700 data points, as I said before. This is a snapshot. It's small text. It's really there just to give an indication of the type of granularity of detail we've got across our care settings. You can see here that in the red columns we've got for any different capability, whether that's patient access to records, whether that's proactive alerts and remote monitoring, whether that's a workforce who are digitally enabled, we've mapped out the difference between an aspirational capability, a foundational capability, and actually where any organisation is at any particular time. And our job is to incentivize and fund the system to shift everything rightwards. Like I say, this is actually real data from a trust. I actually don't know where it's from, but it's a real data. But we've got 1,700 data points to back up our strategy. So this is how we can start to shift things in terms of digital maturity. We already know, for example, in social care, we've digitized 50 providers last year. Next year, that'll go up to 84 providers. This has resulted in a 19% saving in staff time and a 24% reduction in cost around paper, storage and printing. I mean, these are the quick wins. So it's taking this type of approach that we can really start to address those inequalities. The next bit in our strategy, the middle layer, is about integration of information. So how do we share information professional to professional? How do we share information service to person? If you think about any other area of our lives, whether that's online shopping, whether that's Apple Music, whether that's ordering flights, these principles, service to person, exist in all areas of our lives. I think in healthcare, it's clear that this is much less capable in terms of digital technology than it actually is desirable. So that's the principle. What does this mean in practice? Well, for me as a clinician, this is really about being able to see information at the right place and the right time. And one of the things that does this for me is the Greater Manchester Shared Care Record. So if I'm on the intensive care unit in Salford, we've got an unconscious patient in front of us, we know their name, but we don't know anything about them, this record can tell me their medications, their allergies, their recent history, their correspondence, and their blood tests with a single click onto the EPR, electronic record that is. So this integration of information is absolutely key for reliable service delivery, but it's also key to give us population-level insights and innovation. So this is the Greater Manchester Care Record. It's a longitudinal lifetime record which sits across the GP record. Just some stats here to give you an indication of where we are with this. So in October, 250,000 patients were accessed on the Greater Manchester Care Record. Almost 20,000 members of staff looked at this record to guide their care. You can see in the far left, this is moving upwards. It's not enough. There's a lot we need to do to really drive this adoption for direct care. I've talked about direct care, what this means for me as a practitioner, but the other aspect of this longitudinal record sitting across 2.8 million people is what does this mean for our population level insights, our research and our innovation. This is a really this is a great slide actually, it's not mine, but I'm really grateful to the team for bringing this together because this describes on one slide what we're trying to do, and I'll take you through it really, really quickly. The top bit is about sharing information for direct care. So what does this mean when somebody's in front of me in a clinical scenario? The bottom bit here, this talks about how that longitudinal record then feeds a shared data platform across Greater Manchester, what we call our ADSP, or Analytics and Data Science Platform. Within this, at the bottom, we've also got our secure data environment, which is a research environment. So this ADSP, this data platform, this 2.8 million people worth of data can be used to give us real-time dashboards to plan care and address inequalities and understand where we need to do things differently for people. So a great slide. It's complicated, but on one thing that really brings together what we're trying to do. And I'm really happy to speak to colleagues around this afterwards. Well, what does this mean? Let's bring this to life with some real-time innovations. So innovation can include new technologies, new delivery models, or new level insights. There's a lot of things that we're doing in Health Innovation Manchester about the delivering of different technology, but for today, I'm going to focus on some real-time examples of how we've used digital and data to specifically address health inequalities. So a complicated heat map. This isn't my data, it's Dr. Seem Mishra, who's a GP, and Matthew Conroy, who works in our data science team. But this is data which we've drawn from that 2.8 million people database I was describing to you. And what this is a heat map of cardiovascular inequality across Greater Manchester. So no surprise, in the leafy suburbs, it doesn't look very hot, does it? It's all being managed well. But in the inner city and in the east of the city, you can see that that's gone red. And what this is a sort of a multi-factor score based upon lipids, blood pressure, exercise, alcohol, etc., which gives us right down to locality level an understanding of where patients are at the highest risk of cardiovascular disease. Greater Manchester is a huge outlier with cardiovascular disease, and it's these types of insights from that digitisation, from that integrated record, that give us a way to intervene in a completely different way. So we've got this level, this is a cardiovascular score. We could say, well, we need to go to one of these hotspots, one of these communities to try and deal with things differently. But alongside this, we've also got data around specific medication and conditions right down to the individual patient level. So we can, this data for research and planning purpose is de-identified, but where it's for direct care, we can re-identify via primary care, not me and the team, it goes to the primary care and they can re-identify the data to intervene early in these patients who are at high risk of disease. Similarly, so let's talk about one condition, hypertension. Again, I don't know if you can see on the slide, but this is ethnicity. So this is around where is medication and hypertension suboptimally treated according to ethnic groups. And we can see that the top here, white Roma, white Gypsy, Irish traveller, a lot of those communities are poorly served by treatments and interventions to manage hypertension. And again, this can go back to the primary care setting where the primary care team can de-identify this data and understand how they should be looking to intervene with any particular patient, right down to the drugs, the doses, and the other options. It's incredibly powerful, which all comes from that longitudinal, joined-up data set across Greater Manchester, where primary care colleagues can then intervene and understand how they can treat patients differently. Excuse me. So one example in cardiovascular disease where these data sets across 2.8 million people are really transforming care. And to go back to the start of what I was saying, this is why digitisation at the fundamental level is really important, because unless we've digitised our service, you don't get this information bubbling up through to that layer across health and care. Another example is inclisiran. So Health Innovation Manchester have been leading the rollout of inclisiran. Inclisiran is an injectable cholesterol medication. It's used according to strict protocols to control patients whose lipids are under poor control. So again, population level insights to address inequalities. The map on the left is a purple scale. The darker purple is more deprivation. The lighter purple is less deprivation. And again, schematically, what you can see is that the coloured squares, stars and triangles they reflect where we've intervened to manage patients and their lipid profile. This is later data, but with the eye of faith, you can see that the coloured squares and dots sit over the darker purple localities. If you'd looked at this earlier in the project, it would have been even more profound about how we've actually been able to target intervention in those areas. So through the use of deprivation data, through the use of lipids data, we've been able to map right down to the level of local practices where we should be intervening and rolling out this novel therapy. The right-hand side of the graphic there is a little bit around essentially the scale of opportunity across our 10 localities. So we understand the scale of opportunity, we understand deprivation, we bring them both together, and then we've got something which is transformative at the level of the individual patients. 5 minutes, I'll be fine. At the end of the individual patients. So what does this mean? So this is inclisiran, that new injectable anti-cholesterol drug. So this is time, August last year through to real time, and you can see the top curve is actually what we've delivered, the bottom curve is what was forecast. So by taking a really needs-based delivery methodology and a different way to intervention, we've actually exceeded what we thought we could do within Greater Manchester to deliver this new cholesterol-lowering therapy. And you can see, what does this mean? Well, if we deliver 4,280 doses, which we've already done, we'll save 89 lives, save almost £1.4 million, avoid 300 admissions for non-fatal coronary events, and reduce that burden upon secondary care. So through the use of a digitised system, integrated information, we can then overlay a direct intervention to deal with health inequalities. Final piece, and Oliver will talk a little bit more about this later on, but another example of where we're using technology and data to address health inequalities. So Greater Manchester received £7.3 million earlier this year. That's 22% of the national budget from Innovate UK to roll out a series of tech accelerator projects. We've got 11 commercial partners, 7 industry partners to treat patients in a different way. I'm just going to bring 2 of those, I think it's 10 projects, to life here. The first one, and Oliver will talk about this later on, so I won't go into in great detail, is around liver disease. So what we're doing with our partner Solace is building an engine which can then look at patient data to understand where patients are at most at risk of liver disease, call them for screening, and then intervene. Again, directly addressing inequalities. And likewise, working with Gendius to look at chronic kidney disease patients. Again, looking at data in the longitudinal patient record, putting it through an engine, and then coming out with a plan to intervene to address inequalities in health and care. So that's the third and final example. I talked around cardiovascular disease, I talked about lipid management, and now liver disease and chronic kidney disease screening. With these pilot projects, we're starting to understand how we can use that data to address inequalities. So final slide. So I've spoken to you. I started off by saying, look, this is the scale of the challenge in Greater Manchester in terms of inequalities, in terms of digital poverty, and sort of drew the contrast between that and our aspirations as a leading digital city. I then talked a little bit about, well, what's the level of data that we've got? And really, we've probably got some of the best data in the country in terms of our digital and maturity and capabilities. And what we've done within Greater Manchester is transform that data from maturity into a strategy, into a delivery plan. And as I've outlined, that delivery plan has got 3 main things. Digitize, basically buy stuff and roll it out. Integrate, share information with appropriate permissions for direct care and secondary care, and then build on top of that in terms of innovation and new models of care. And I've given you some examples around where, by looking at deprivation indices and sort of cardiovascular risk scoring, we can really use innovative models to target our interventions to decrease health inequalities and therefore improve and save lives. So thank you very much for your time. Really happy to take questions later on in the day, but I think we're also on a panel now, so a good opportunity to talk then.